Hi everyone, welcome to today's episode of Face Facts. On today's episode, I have the incredibly talented, skilled, knowledgeable consultant surgeon, Miss Shireen Ali. She is a gynecologist, obs and gyne specialist, and she specializes in genitourinary symptoms. Today we've talked about this in particular, GSM, genitourinary symptoms of the menopause. We've debunked some myths and we have educated you about the anatomical changes that can happen during the menopause, the perimenopause, the options for treatments, and what you need to know when you're going through this very important phase of life and how you can look after yourself. I hope you enjoy this episode. Hello, everyone, and welcome to today's podcast. So on today's podcast, on Face Facts by Dr. Yusra, I have the amazing, brilliant, phenomenal, 25 years experience, Miss Shireen Ali.
Thank you.
Consultant gynecologist with a special interest in urogynecology and menopause. Is that right?
That's right. And vulval conditions.
And vulval conditions. Love it. Okay. So today we're going to be talking all about some of the overlooked symptoms of the menopause, about genitourinary conditions or symptoms that people might not know about, and also bust some myths about the changes that women go through in the menopause and HRT. So let's get started. Thank you so much for coming.
Thank you so much for inviting me. And as usual, always a pleasure with, talking with you. It's amazing.
I love having you. So those of you who don't know, Miss Shireen Ali is part of our clinical board. She's responsible for all gynecology and obs at our clinic. You've helped me as well when I had my babies and other things over the last few years, and I have a lot of respect and love for you. So thank you so much for coming. For those of you watching and not listening, my skin is peeling because I've had a skin peel. I'm not contagious. I don't have any scary skin conditions. I forgot to say that on my last few podcasts. And so I think everyone that's watching is thinking, what is wrong with her skin? So I've had a skin peel. I've done a whole podcast on it, a whole YouTube video on it. So don't be afraid. This is normal. And,
which I have watched as well. And it's amazing. It's such a good guide actually for people who are worried or scared about having a skin peel. And can I just say the skin that is coming through looks amazing.
Oh, thank you. Do you know, I'm going to do a podcast with you about intimate peels because that's something that we've introduced recently. But we'll do that at another time because we're talking about vagina today, genitourinary symptoms, the vulva. And I just want to anatomically explain what that is because I think a lot of people don't know. You know, this is not my forte. So I'd love the people on here to just understand what is the vulva? What is the labia minora? What is the labia majora? All of that kind of stuff, because people don't want to talk about it. There's a lot of stigma, there's a lot of fear, there's a lot of, embarrassment and shyness. And I think we just need to have an open discussion about this. The changes that happen with the menopause, the vulval skin is part of the skin. The skin is the largest organ of the body. And there are changes that will happen in the outside on the skin.
Yes.
In the same way that we lose collagen in our face, we lose collagen down below. In the same way we can get pigmentation in the face, we can get pigmentation down below. There's a whole range of different treatments. But today, we're focusing on genitourinary symptoms, something that you're an expert on, that you've been treating for decades now. And I'd love to hear more about it. So anatomically, just talk us through what is the vulva, what is the labia minora, what is the labia majora?
So the simplest way to describe this is that the outside is the vulva and the inside is the vagina.
Okay.
And I think if you look at the way things are described in general, when you're sitting with friends and family or you're watching a social media clip or anything on the television, there's a very popular program on the television where they're talking about vulvas
Really?
and vaginas, but they refer to the vulva as vagina, which is incorrect. So
that's contributing to the confusion, right?
That has. And even for some doctors, for some nurses, sometimes it's difficult for them to actually understand or be absolutely sure about which is vulva, which is vagina. So I would always say, keep it simple. Life is simple. So the outside is the vulva and the inside, from where the baby comes, is the vagina. And on the outside, you have the softer part, the more squishy part, which is the bigger lips or the labia majora, comes from the word major. And the thinner, smaller lips that basically cover or outline the opening of the vagina are the smaller lips or the labia minora.
So is the labia majora and the vulva one and the same?
Yes, so the vulva includes the labia minora and the labia majora.
Love it. Thank you.
Simple.
So there's a lot that we can talk about, and we'll do a whole podcast, I think, on vulval atrophy. But We want to talk about GSM, or genitourinary symptoms. Talk to me about what that actually is.
So it's a terminology that is fairly new. So historically, we have been taught, when I was becoming a doctor, when I was reading textbooks, the terminology vulvovaginal atrophy, vaginal vaginitis, vulvovaginal vaginitis, these are the terms that were used. But over the last 10 to 15 years, we've realized that this is only one symptom or one sign of the time period of perimenopause and menopause for women. And there is a lot of other things that happen down below within the genitourinary syndrome, and it doesn't actually talk about that. And hence the terminology genitourinary syndrome of the menopause, or GSM, was put together, because that doesn't just include or talk about vaginal atrophy or changes in the inside, the vagina, but it also talks about changes on the outside, which is the vulva, changes around the urethra, which is the little hole, the water pipe, end of the water pipe that opens into the vagina.
Where you pee from, basically.
Yeah, where you pee from. And also the bladder itself, the bowel, and the pelvic floor. So it basically then covers all of these aspects. And, with time, people have realized that it's not just atrophy. There's lots of other things that happen during this time period as well, which come under the description or under the terminology GSM.
Genitourinary
syndrome of the menopause. So GSM.
So what are those changes? I mean, when we're talking about facial changes, I often say the face changes in layers, the skin, the muscle, the fat, the bone, all of it changes. All the layers of the face are change as you age. Presumably down below, the layers are changing as well. The muscles are also becoming weak. There's multifactorial or multidimensional changes that are occurring. Can you talk me through that?
Yes. So basically, our body has millions of receptors that are sensitive to estrogen, progesterone, and testosterone. And when these receptors don't get what they are used to, then changes happen. So the declining levels of estrogen, the declining levels of testosterone bring about various changes in various parts of the body. So the declining levels of estrogen, basically, like they would do for the face, they do the same thing down below, where the different layers of the skin start thinning. The support structure around that skin starts thinning. Similarly,
like the muscle, when you say support structures, you
so
mean?
basically the subcutaneous tissue, the thickness of the subcutaneous tissue, the vascularization, the blood vessel formation, all of these things start changing. And when that change occurs, then the functionality of that structure changes. So this doesn't just happen in the vulval skin, it also happens in the bladder, it happens around your bowel, and most importantly, it happens within the vagina as well. So these are the main changes that happen. And as a result of these changes, what happens is the flexibility in the skin goes. The skin becomes thinner, not just on the outside, but also within the vaginal skin, or the scientific terminology is within the epithelium of the vagina. That changes as well. And one of the commonest things women would say is that the stretchability, the stretchiness of the skin is gone. It feels a little bit more dry. It feels uncomfortable. It feels different. It just feels like it's throbbing. It's painful. It's burning. So these are the things that can basically be experienced by a lady.
Interesting. So I have, my expertise is in facial aesthetics, and I often look after men and women, but the vast majority of my patients are women, and women who are in the perimenopause, who are kind of edging that way towards the menopause. We know that the perimenopause can be 10 years before the actual loss of period. Because people think that actually the menopause is just that year where their periods disappear. But actually, the physiological changes, the hormonal changes can happen a decade or more before the loss of their period, because estrogen, progesterone, and testosterone starts to reduce from the age of 35. So often I see women in their late 30s, early 40s with symptoms that they don't know are related to the menopause. For example, pain during sex, recurrent UTIs, dryness down below, loss of libido, recurrent thrush. They feel that their skin has become a lot drier downstairs. When I say downstairs, I mean, you know what I mean. And they don't want to talk about it, or they don't often talk about it. And they open up in the same way, I guess, when I go to my hairdresser, I tell her all about my life problems. They tell me about theirs. And I say, well, our expert to see here is Miss Shireen Aleem. But what I find really interesting, and you and I saw this yesterday in clinic,
Yes.
was one of our patients who seems to have been suffering for a very long time, but has only now just started to request support. She's postmenopausal. And there's a lot of procrastination because maybe people don't think there's treatments, or they don't think it's related to the menopause. Why do you think there is procrastination to actually seeking care?
I think there's a number of reasons. Things have improved compared to 10 years ago, even in front of me, in my sort of time working as a consultant for the last 15 years and in the NHS 25 years. I can see that there is a big change, but still not enough. Still, it surprises me, like, with certain situations where women don't actually come forward with it. One example is fear of HRT, and fear that if I go there, the only treatment may be that I need HRT, I need a patch, or I need some gel, or I need some tablets, and I really don't want to try that. And they may not come forward. And also, unfortunately, the information that's out there may be a bit misleading as well. And that's why it's important to look at trusted sort of resources, to look for the right information and then equip yourself with the right knowledge so that you can come forward and talk about it. And then, of course, the most important thing is that you just don't feel confident to talk about these things. I'm not sure if confidence is the right word, or embarrassment is the right word. It's just human nature. This is that part of the body that you feel uncomfortable to talk about, but also you might feel that what are people going to think? Maybe I'm entering into that age group where this is natural and normal. And one thing through your podcast that I'd like to say is that it is not natural and normal to feel like this. The average age, or you could say sort of the average timeline of menopause is between 45 to 55, but women much younger than 45 can go through the perimenopause and menopause. And sometimes the problems of menopause can go well beyond 55. So this is just an average. So during this time period, a lot of women might feel that this is natural and this is meant to happen. Yes, those changes can happen, but they can be fixed. And there are different modes of treatment, modalities of treatment that you can take. So coming forward and just having a chat. When you go and speak to somebody doesn't mean you're going to be forced to take treatment. Just having that knowledge, okay, these are the options out there. And yes, they suit me, or no, I don't think I want to try them, which is fine.
Sorry to interrupt the podcast. I am coming to you to say, if you're enjoying this, then I would really love for you to like, subscribe, follow along, and share this with anyone who might find this useful. We are investing a lot of time, energy, and resources into bringing you the best of the best in education, all about faces, bodies, aesthetics, and wellness. And I want to continue to do that, but I need you to subscribe. And if you have any questions, if you want us to address any particular topics, then please leave a comment and we will certainly create videos for you to address those. Thank you, and I hope you enjoy. When you and I first started talking about this, and you told me the vulva ages as you age, I was shocked. I think a lot of people don't know that,
Yeah.
And then that's scary because you think, oh my God, I'm prepared. I've been using retinol, I've been using SPF, I've been, doing injectables, I've been doing everything that I can to maintain my aesthetic health, to maintain how I look on the outside, on my face. And nobody, people barely talk about their neck, let alone down below. Is there anything that people can be doing preventatively for down below?
So again, I think it depends on their symptoms. And compared to the systemic HRT that you take by patch or gel, which you may take while your symptoms last, and then you stop. And if your symptoms are no longer there, you don't have to take it. Vaginal estrogen does need to be continued in the long term. Preventative measures that are other than vaginal estrogen, I'm not sure whether there is any good preventative measures there. But what you could say, one of the preventions is, or one of the precautions is that when your symptoms start, try and get that treatment sooner rather than later. Because it is easier and simpler to reverse the changes when the changes have just started happening, rather than 5 or 10 years down the line when the skin is too thin, the flexibility of the vagina is not as much as it was 10 years ago. So if you get that treatment, whether you want to call it prevention or early access or early intervention, it helps. But other than that, at the moment, I can't think of anything. But what I would advise is that don't leave it too late. If you have those symptoms, seek advice sooner rather than later. And try and, if treatment is indicated, then try to get your treatment sooner rather than later.
What about Kegel exercise? I mean, I'm sitting here opposite you thinking, oh my God, I'm doing my Kegels. I have a chair in the clinic called the Emsella, which you've seen, which is 20,000 Kegel exercises in half an hour.
Yes.
Which I'm going to jump on now. It's like a reminder to self that I bought after I had my third child. And it was amazing. And it's amazing for so many of our patients, even patients who have vaginismus, which is really interesting actually, because it's pelvic floor tightening. But is that something that you encourage? Do you tell people do your Kegel exercises? Is it something we should be doing regularly? They talk about it while you're pregnant, but then nobody ever talks about it.
So we talk about vaginal estrogen, pelvic floor exercises, talking about your problems day in and day out. Anybody who comes to my clinic knows that you may come to discuss one symptom, for example, stress urinary incontinence, but we have a very holistic approach. So pelvic floor exercises is hugely encouraged within our service, and we encourage supervised pelvic floor physiotherapy by a specialist. But of course, then there are new things such as your Emsella chair, which helps. I've tried it myself. It's pretty phenomenal. And pelvic floor changes steadily over time, especially for women who've had children. As we give birth, the pelvic floor does change. And just like the rest of our body, like our arms, our abdominal walls, our thighs, what do? We exercise them so that they maintain their muscle mass, they maintain their strength. Why should we not do that for the vaginal area or the pelvic floor area? It's a huge muscle. It's one of the biggest muscles. The levator ani muscle is one of the biggest muscles of the body. It needs exercise. And as we age, especially with the declining levels of estrogen, from the age of 40, every decade, we lose 10 to 15% of our muscle mass. And that happens to the muscle mass of the pelvic floor as well. So that pelvic floor has gone through a bit of stretch during childbirth, and then when it loses the estrogen, and then when it loses its actual mass, it becomes weaker. So that same sort of stress and conscious that we could just about manage by doing our pelvic floor exercises or squeezing our pelvic floor and not leak, that suddenly changes as we are going into the perimenopause and menopause. And that happens due to a background of other changes as well. So that's why it's important to do the pelvic floor exercises, just to aid and help that muscle, maintain its strength. So pelvic floor exercises, there's no two ways about it. It's important that it's done.
So interesting. So when you say stress urinary incontinence and changes that happen when your pelvic floor weakens, what are those symptoms? How do you know that your pelvic floor is weakening? What is stress urinary incontinence?
So incontinence, there are 3 types of incontinence. You have stress urinary incontinence, where any exertion, whether you're going to shout at somebody, shout at your husband or shout at your children, you reach out for something, you jump, you cough, you laugh, you will leak. So any exertion will lead to leakage due to weakness within the pelvic floor. You then can also get incontinence due to overactivity of the bladder. So women will tell you, I've been outside walking with my dog and suddenly this urge comes upon me and suddenly I just leak. And then there is another group of ladies who will have a bit of both. So they will have a little bit of stress and also a little bit of overactivity. So these are the 3 types of incontinence. Stress incontinence mainly happens with exertion.
And the primary treatment for that is pelvic floor exercises?
Definitely. So pelvic floor exercises, lifestyle changes, weight loss. So these are some of the primary factors that can increase stress urinary incontinence. And in order to either avoid it or at least to try and maintain sort of your symptoms don't get any worse, it's important weight reduction and pelvic floor exercises and lifestyle changes. So what you drink, what you eat, these are very important factors that help in this situation.
So you mentioned childbirth. Presumably you're talking about vaginal birth. What about if you've had C-section, or what about if you've never had children? Do you still undergo these changes?
So women who've never had any children, they can also have stress urinary incontinence. But the risk of them or the chances of them having stress urinary incontinence is a lot less compared to somebody who has had children. Similarly, the evidence out there is that you don't get stress incontinence just by the passage of the baby through the birth canal. You can get it by just carrying your baby. So, the baby itself, it's a bump, it's a big bump in your body that puts pressure on your pelvic floor. So that itself can give you stress incontinence. And that's why if a woman opts for cesarean section because she feels that it will help her not getting stress incontinence, there's no 100% guarantee that that will happen.
Very
so just carrying
interesting.
the baby can cause that. But it's not all doom and gloom. The risk is still small. So, many women who have had many children are absolutely fine. It's just about looking after yourselves. Like anything else in your body, when something happens, if you're diabetic, if you have high blood pressure, you want to either avoid getting that. And if you get it, you want to do the best things to keep your health optimal. And the same applies to women and women's health, So
What about women who have procrastinated, they've not sought treatment? What if you don't seek treatment? What kind of happens? What's the potential bad things that can happen?
So it depends. I think women's health is a subject that is much better approached now. And I think more and more women are coming forward and talking about it compared to 15 years ago. That's not a very long time ago. It's just about getting improved and it is getting better. I think if I would encourage them to come and talk to doctors, and if they don't want to talk to us, maybe talk to a family member or a friend. If they don't, you can miss things which could be easily treated. And if it's too late, then it is harder to treat. It can still be treated, but it is harder to treat. But then, of course, then there are some serious things which can get missed and they need serious attention. So the one thing I would say is that if you feel uncomfortable talking to a doctor or a medical professional or a nurse, then go and talk to your mom, go and talk to your sister, go and talk to your friend, your husband, your boyfriend, whoever you feel comfortable with. Go and talk to someone and try and discuss it. Don't decide on your own that I need to go and seek help or I don't need to go and seek help. If you can.
The thing is, what I find is that, husbands don't know, boyfriends don't know, brothers don't know, sisters don't know. And our mums, the older generation are used to kind of just not talking about menopause. I don't know what my mother's menopause was. I do know that she was afraid of HRT and never took HRT because she was of that generation where that WHO study had come out that said HRT was bad. And obviously that's been debunked now. And, that's been put into perspective now. But after that, 1 million women stopped taking HRT because they were afraid that HRT would give them breast cancer. So they suffered in silence. So I hear you, but I would say speak to a medical professional because they can cut through the misinformation. And there's a lot of misinformation out there. And this is something that we were talking about earlier, which is myth busting. So if I had to ask you, out of all of the myths that you've heard and misinformation, there's lots out there and we can do a whole podcast on that. But if you wanted to debunk one myth about genitourinary symptoms of the menopause, what would that be?
I would say the one myth which I almost see on a day in and day out basis of my medical profession is that maybe two myths. Can I debunk two myths?
Yes,
okay. So is women who are already on HRT, whether they're on a patch or gel or tablet, they sometimes get surprised when I will say, actually, we need to add vaginal HRT or vaginal estrogen because that is what is going to help. The topical, the estrogen that directly is applied to the vagina. And sometimes they won't come out and say, why are you prescribing? But I have now in my professional capacity always made a point of explaining things to them. So I will always tell them that the reason I'm doing this is because this works in a completely different way to systemic HRT that is there for your body, for your hot flashes and your night sweats. And I think it's very important because if you don't explain it to them, they won't take it. And this is a real problem. The fear of, why do I need vaginal or why do I need additional? Am I taking too much HRT? So I think it is our responsibility to explain it to the ladies.
So you can have systemic HRT and topical vaginal HRT.
Yes, you need both. You need both. So one systemic will not work. This is one. And the other thing is that I will see ladies who are much older and have taken their HRT and are fine and no longer take HRT, or women who went through a menopause without a problem, never took any HRT, today, but are older now and have come to me with symptoms of vaginal discomfort and urinary frequency, urgency, throbbing. And to them, I say, I'm going to give you some vaginal estrogen. And many years ago, we used to use the word vaginal estrogen. We never used the word vaginal HRT.
Okay.
But then I would get patients and lovely ladies contacting us. Oh, are you sure that I need to have this treatment because the leaflet says it's vaginal HRT? So we need to do an entirely separate podcast on the leaflet, information leaflet within those boxes, which are highly incorrect, unfortunately. So that's why in my practice now, I've started using the word vaginal HRT. So women already know what we're talking about, is because when they go and open those leaflets, it uses that word. So the worry then by the women is that why now? Why is my doctor giving me HRT now? So that's another myth that I would like to debunk, that this is different. You can either call it vaginal estrogen or vaginal HRT, but what we're really doing is giving topical estrogen to help those symptoms. And these symptoms can continue for life, and the treatment required can be lifelong as well.
Wow, so interesting. Thank you so much. If I just want to summarize now, the top symptoms that people might be experiencing in terms of GSM, what are those symptoms? Yesterday, you saw a patient who had fusion. Is that a symptom? And can you explain what fusion is?
So estrogen is protective for the vulval skin. And when estrogen is less, low, or none, then there can be changes to the appearance of the vulval skin. There can be fusion of the vulval skin.
So the outside and the inside fuse.
Inside can fuse. There can be changes in architecture, and the tissue basically doesn't look as, plump or normal as it used to. So that changes. There can be discomfort. And one of the commonest symptoms that ladies will come with is discomfort with intercourse, pain with sex. And urinary symptoms are very common as well. Urinary infections are common. So there is a whole list of things that can happen, but these are probably the commonest symptoms with which women will come.
Thank you so much. That has been so, so helpful. I'm sure our listeners would love this episode. Thank you for joining, and we'll see you again next time.
And thank you for having me. Always a pleasure.